Hi, my name is Meg Fraser. I am a member of the HFSA Communications Committee. I'm here with Dr. Robert Page. We've selected your presentation at the committee meeting in Philadelphia as one of the most important topics, and we would like to highlight it today. Please share who you are, where you work, and your role at your institution.
Thank you so much, Meg. So my name is Robert Page. I am a full professor at the University of Colorado School of Pharmacy and School of Medicine. I have been working with the Division of Cardiology for over 2 decades. I'm the clinical pharmacy specialist for the Division of Cardiology section of heart failure and heart transplant, of which you used to work with us. So yeah, and again, I work in both the outpatient and inpatient settings. I work very closely with all of our providers with the management of both outpatient heart failure and heart transplant, as well as left ventricular assist devices.
Can you please summarize the most important points from your talk at this meeting?
Oh, absolutely. So it was a fairly controversial topic. It's the use of ambulatory inotropes within patients who really don't qualify for advanced therapies. There are individuals, I hate to say this, who didn't get the bid to the fraternity, and so what do we have? And very often we don't have a lot of options. One option is inotropic therapy, and the key thing is as you well know, as you managing patients with heart failure, we've always been taught that, gosh, based on data for the last 30 years, of course, since the last really good published data has been 2009. When we use inotropes, primarily the mortality rate is up to about 50% or so, based on both data with both oral and intravenous. And so, it seems almost absurd, like you're going to send our patients home on inotropic therapy, but in all honesty, the data that has been published thus far has not really been in the patients that we're seeing now, and that's really for palliative treatment. And so we don't have a lot of great data, but the data that do exist out there is primarily related, when you put the data together, really there's an improvement in New York heart failure, NYHA functional class, also patients' quality of life. But unfortunately, there is a neutral effect upon hospitalization, and actually a neutral effect on mortality, really, within this population. But again, that's based upon only a meta-analysis of a few number of studies. Again, we don't have a lot of data out there, but I think the most important thing to think about is the fact that we should not be cutting our noses off to spite our face, or cut our face off to spite our nose, whichever one that is. But nonetheless, I think it's something we need to be considering. Again, here in the United States, dobutamine and milrinone. And so some of the things just to consider with regards to that, again, as a clinical pharmacist, is making sure we really reach the right patient. And so those are going to be individuals who do not have obstructive disease, number 2, that are class 4, number 3, that do meet Medicare requirements, because remember, the majority of our patients, this will fall under Medicare Part B, and so therefore they will still have to pay a 20% copay. So patients need to understand that, again, dobutamine is fairly cheap, but milrinone can run anywhere from $1,000 to maybe $3,000 for a session. And so making sure that aspect is covered. And again, end organ damage. A lot of times we can adjust, particularly with milrinone, it is cleared renally, and so therefore you have to adjust the dose. The nice thing is a lot of dialysis centers are now allowing that. Before they were like, no, we're not doing that. That's not the case anymore. The other issue is with regards to hospice. Hospice is, before, you remember when we would deal with it, they were like, no, we're not sending people home on IV inotropes.
Right.
But I think now we have a lot more acceptance, and so that's the thing. And so really this session itself was designed to really bring this concept back to life, number 1. And then also number 2, and from the other speakers that were there, Dr. Omberdecker, Dr. Allen, we talked a lot about patient-centered decision-making and the use of aids in order to assist with that, because really it's what the patient wants. And again, we're thinking about this as palliative care. And so another point, though, is unfortunately you got to initiate these in the hospital setting to begin with, to find that right dose that matches that patient. And so, yes, it is an interdisciplinary it really requires an interdisciplinary approach when considering this. But again, it's all about our patients and what they want.
Great points. Thank you for your time.
Thank you so much.